طيب. Good afternoon everyone and welcome to this session. So this is one of the sessions as part of the SHARP longitudinal seminar series, and this is about assessing the quality of evidence using the GRADE approach. So this is my disclosure. I'm a member of the GRADE working group, which is a subject of this presentation, and a member of its guidance group, but I don't have any financial conflict of interest. So the goals and objectives of this presentation is first to define what we mean by quality of the evidence. Second, to discuss the factors that affect the rating of the certainty of the quality of the evidence. So just to give you a quick background, the GRADE working group started as an informal group in the year 2000. So that's about 17 years ago. The goal was to come up with a unified methodology or framework for assessing the quality of the evidence and developing guidelines. So if you are familiar with clinical guidelines, you will notice that on the same topic, the same clinical question, you will have different guidelines giving different recommendations. So one example is PSA screening for prostate cancer in men. If you look at different guidelines, they will have different recommendations. But even if you have the same recommendations, they will have different ways of presenting them. So some of them will say grade A, B, C. Some of them will say level 1, 2, 3. So different approaches of doing this. So the purpose of this group was to try to come up with a unified approach and to make the approach of doing this systematic and transparent. So currently more than 100 organizations have adopted the methodology. The most maybe well-known organizations include the World Health Organization over here, UpToDate, if you use UpToDate, the CDC, the American College of Physicians, American College of Chest Physicians, and lots of organizations across the world, including Europe and North America. So let's start with our first objective of defining what we mean by quality of the evidence. So this is, I'll start with a meta-analysis. So this is a forest plot. And the reason I'm showing this is that typically what we rate our confidence in is what we call a pooled effect estimate. So we have a clinical question. So what is the effect of medication A versus B on the outcome of mortality? So we gather the evidence, which might come from not one study, but more than one study. And in order to get one estimate or the best estimate, we do what's called a meta-analysis. And this is an example of a meta-analysis. So who is familiar with meta-analysis and forest plots? Just if you could. Okay. So to give you a bit of guidance, so this meta-analysis lists all the studies over here on the left that have assessed the outcome of interest in their studies. And in the meta-analysis, we list all of these studies. We include for each arm, so in this case it happens that it's about heparin versus control. In each arm, we list the number of events and the total randomized in each arm. So this is the data we get from each study. And this is the effect estimate from the individual studies. And the software assign weights for those studies based on the number of events, based on the total number of participants, and then displays the effect estimate. So this number, 1.06, that's the point effect estimate. So this is the line of no effect. It's a risk ratio of 1. Everything above 1 is increased risk of the outcome. Everything below 1 is decreased risk of the outcome. So this line, that's the point effect estimate. That's the 1.06 here. And then this line, the segment, represents the confidence interval, in this case going from 0.92 to 1.23. So again, for each study, you will see that this point effect estimate and the confidence interval are both plotted here. And then at the end, all of these studies are pooled, and you get what's called the pooled effect estimate, 0.93. So that's it, this diamond shape. And the value goes from 0.88 to 0.99. Okay? So this is the meta-analysis. And just a quick observation, you would see that if you look at the individual studies, none of the individual study is actually statistically significant, or the confidence interval doesn't cross the line of no effect, correct?
Yes.
So the pooled effect estimate or the meta-analysis provides the advantage of pooling the data and having more data to provide a more precise effect estimate. Another value you should be familiar with when you look at the meta-analysis is this number, the I-square, which is the indicator of heterogeneity, and we'll come back to this number later. So going back to our starting point. Our starting point, we said we want to assess the quality of the evidence. In other terms, when I look at this number, so this meta-analysis tells us that the best estimate is 0.93, and then the next question, how much confidence we have that this is reflecting the truth or the true value, okay? So that's what we call the quality of the evidence. In some cases, we call it certainty of the evidence. So these are equivalent terms. Any question about this part? So in some cases, we have only one study answering our question, so we don't need to do the meta-analysis. We just look at that one study, let's say this one, and then we assess our confidence. So let me ask you a quick question, maybe not that quick. So if I ask you how much confidence you have in that number being reflecting the truth, what would be some of the factors that affects your confidence in that number? No? Okay, so whether it crosses 1 or not, so an indicator of how precise this result is. So if it crosses 1, you have obviously less confidence. Okay.
And also the quality of each individual study as in presenting the bias or
Okay.
of its results.
Okay.
They
Yes.
might not cross the line, but
Yeah.
there might be low bias that
Okay.
the quality.
So what you are saying, how much bias there is in each study. So with the same graph, it could be the case that all of these studies are very biased. So even if this is precise, I don't believe the result. Or it might be the case that all of these studies are very well done, so at low risk of bias, then I have more confidence in this result, irrespective of the precision.
That's why we use grade and the risk.
Yes. So risk of bias, so far we discussed risk of bias, we discussed precision. Anything else? Okay, we'll get to them, but this is a good start. That's
the elements you're the elements of grade, precision and bias, and the other two.
The other 2 or 3. We'll get to them. Okay.
Consistency.
Yes. Okay. That's the next one. The I-squared. Exactly. So if I tell you that this is the point effect estimate, this could be coming from studies that are very homogeneous, so all of them giving me the same result or hinting to the same result. Or this pooled effect estimate could be coming from studies, some of them showing lots of benefits, others showing lots of harms. I could still put them into a meta-analysis. The meta-analysis will still give me a point effect estimate, which could be 0.93. But in the case where there's lots of heterogeneity, I have less confidence as opposed to all the studies repeatedly giving the same result. It's like when you look at the literature and you see that someone looks at this question in a trial, they get the same results, as opposed they get conflicting results. Okay, so we'll get into this in more detail. I think that's a good start. So the definition of the quality of the evidence or the certainty of the evidence is the extent to which we have confidence in the effect estimate. It's like saying not all studies are created equal. Not all bodies of evidence are created equal. Sometimes we have confidence that this is the truth. Other times we don't have that much confidence. And what is important is that this quality of the evidence is assessed by outcome and not by study. So typically, if you look at the traditional systematic reviews, that would show you for every study how much risk of bias there is in every study. We still do that. We have to do that. But this is taking it to a step further, which is how much confidence I have in that outcome, the evidence for which could be coming from a number of studies, not just from one study. Because actually, when you think about decision making, when you make decision, we are balancing outcomes. So we have a reduction in mortality, or a reduction in bleeding or stroke versus increase in bleeding. So So we're thinking in terms of outcome, not in terms of studies. So I would like to know, okay, that outcome, how much confidence I have in it. And the risk of bias from the individual studies will factor into that quality of evidence in the outcome. Okay? So this is an example. A medication X is reported to reduce mortality from heart disease by 30%. The question is how much confidence I have that it is 30%, as opposed to, it could be 30, it could be 40, it could be 20, it could be 0%, it could be increase in mortality. Okay. So the confidence in the effect estimate or the quality of the evidence is actually a continuum. So if you think about it, I'll tell you this trial or this meta-analysis is giving us this number. And how much confidence you have in this number. It could go from zero confidence. So if you tell me there's a small trial, or I'll tell you there are 2 trials. Each one of them recruited 2 patients. The 2 trials were not blinded, they were not well done, and one of them shows reduction, one of them show increase. I tell you how much confidence do you have if I pull these results. You probably say it's probably like 0%, it's like any guess. Or I tell you that for this outcome, there have been 10 large trials. The trials were very well done, they were all blinded, allocation concealed. They all examined the exact population I'm interested in. They all gave consistent results. And there's no publication bias, there's no heterogeneity, they're all giving me the same result. Then I would have lots of confidence. So this is kind of going from 0% to 100%, and it could be anywhere in between. So it's a continuum. However, where we are in terms of methodology, understanding the methodology of research, we don't have the means to get a formula and put in some numbers, blinded, not blinded, I-square of 20%, and then come up with an exact confidence value. I cannot tell you I have 56% confidence in this number. So that's why, in order to be reasonable in the way we assess this, we have categories. So we say high, moderate, low, and very low. Okay, because I'm more comfortable to say this is high versus moderate, as opposed to say I have 56% as opposed to 55% confidence. So it's just a practical way of categorizing certainty of the evidence. So it could have been 3 categories, it could have been 5, but when people came up with this categorization, they thought that this is the most practical and probably easier to communicate. So there are different ways of defining what we mean by high. One of them is the following. So there's considerable confidence in the effect estimate. Moderate, there's less confidence, and if you do further research, there might be a change in that estimate. And the lower you go, if you say this is very low quality or very low confidence, it means that any estimate of effect is very uncertain, and maybe with the next study it will vary. It would go from reduction in mortality to increase in mortality. So this is what we mean by certainty of the evidence. So in terms of the factors, we already discussed some of the factors that affect the certainty of the evidence. So I already posed this question. So let me show you the overall framework of how we do this, and maybe next we can go and discuss those in detail. So this is kind of the overall framework. So first, we look at where the body of evidence is coming from. Is it coming from randomized trials, or is it coming from observational studies? So if it's coming from randomized trials, we start with high confidence. If it's coming from observational studies, we start with low confidence. And this is because with observational studies, even if you adjust for confounding and you do your best with matching, with analysis, etc., we know there's always residual confounding, even with the best statistical methodology. So there remains confounding, so there remains a potential for deviation from the truth. Next, we assess a number of factors: risk of bias, inconsistency, indirectness, imprecision, publication bias. And if any one of these is existent, the initial confidence, so let's say we started as high, might go down due to any one of those. In some cases, there are other factors that could bring our confidence up. We discussed those. And based on these factors, you might start with high, end up with high, or go down to moderate, low, or very low. If you start with low confidence with observational studies, you might go down, or in some cases, not very frequent, you might go up if you have some of these factors. There have been lots of discussions and resistance to observation studies starting as low. So many people say in our field, you can never do RCTs because of it's unethical, because it's not doable, for all kinds of reasons. And people say it's unfair. However, this argument doesn't justify why we would suddenly have higher confidence in observational studies. Even if you cannot do an observational study, there will always be residual confounding. So people still believe that observational studies should start as a lower confidence. But one of the changes that have been implemented recently or being implemented is that, we could start with observational studies as high. However, when we do the risk of bias, we have to take into account the residual confounding, which in most cases will again bring you down. Consistently, the risk of bias will apply, and then you'll go down to typically low, maybe in some cases to moderate. Okay, so let's start with the risk of bias. So risk of bias is done at the level of the individual study. And this is related to factors at the study level that might introduce bias, meaning a systematic deviation from the truth. So thinking about randomized trials, we think randomized trial takes care of residual confounding. But what are the things that could introduce bias in a randomized trial?
There's selection bias, to start with.
Okay.
Performance bias.
Okay.
Intuition bias.
Okay.
Detection bias, and reporting bias.
Okay. Sarfina Phil? Yes, okay, so we'll go over these and maybe with some slightly different terminology. So some of them, selection bias refers to sequence generation, lack of blinding that refers to performance bias, sometimes measurement bias, the violation of the principle of intention to treat, loss to follow up, and early stopping for benefits. So let's go over these. And again, just to keep the big picture, we're talking now at the level of the study. If you do this, if you start with the study and you're assessing the bias that could have been introduced to the study, these are the factors we look at. So let's start with this. So question, why is randomization important? Remember on the 2 slides back, we said that we think there's more confidence in randomized trials as opposed to observational studies. So what is the thing about randomization that gives us this higher confidence? Specifically in terms of randomization, what's special about randomization?
It controls for confounders.
Okay. Yes. The randomization. Okay, so that's the.
So when we do the randomization and we have 2 arms, we controlled for all confounders that we know about and we have foreseen and unforeseen.
Yes, so we'll get to that. So I just want to cover the issue that this represents the population of interest. So in epidemiological studies, when we take a sample to measure characteristics of the population, let's say age, body weight, cholesterol level, etc., we want our sample to represent the original population. So when we say the average weight is X, that would reflect what is the average age in the overall population, because we're not taking all the population and measuring weight. So in order to get a sample that is representative, we do what's called a random sampling, meaning that we make sure that the sample is representative and not selected in a certain way. So that's a bit different than the process of randomization in trials. So that's random sampling for the purpose of representativeness. So when you do a trial, the process of randomization is how you allocate participants to the 2 arms or more of the study in a way that is random, meaning that there is no preference for which participant is going to which arm. So this is the randomization. And you could imagine that when you recruit participants in the study, those participants do not represent the overall population, because let's say you are recruiting at AUBMC, your patients will be sicker, might be older, might have more comorbidities. So actually they don't represent the overall population. So that's not the representativeness part, but you could still randomize them into a trial. So that's the difference between random sampling and randomization.
I just want to add something. I remember that randomization is good because it will decrease the systematic bias. It will decrease
Yes.
the amount of systematic bias.
Yes.
Meaning that is, if you just, what you just explained, that if you actually randomize people to this group and to this arm, and you're not aware of which one is which, if you're also blind, which is makes it even better, then you're actually probably having, systematic bias, like
yes. So I
you're
get
more aware of the truth. It will reflect the truth.
yes. So the definition of bias is a systematic deviation from the truth, and this is what this whole list of things is trying to do, to make sure that there is no systematic deviation from the truth. The key point is the key idea is the idea of confounding. So confounding, it's a concept that is sometimes confusing, but the one example that works well when I give the example is the example of lung cancer. So if you think about, if I tell you they've done a study and they looked at whether people have matches in their pocket or الداحة, and they have lung cancer, and they find that those who have matches in their pocket are more likely to have lung cancer. So this is an association that is observed. Does this mean that matches in the pocket lead to lung cancer? What's the answer? No. Why are we observing an association between having matches in your pocket and having lung cancer?
Because it is associated with the cause of lung cancer,
smoking. لأنه in this case, smoking is a confounding factor because it's confounding the relationship between matches in the pocket and lung cancer. لأنه we know for pathophysiologically, etc. No, there's no association. There could be no association between having matches and having lung cancer. However, there's a confounding factor, smoking, that is associated with both having matches and having lung cancer. So it confounds the relationship between the two factors. And if we don't take it into account, we don't adjust for it, it will look like if matches cause lung cancer. So this is the concept of confounding. So if we are looking at a trial of aspirin and having, let's say, stroke. Okay, so you take aspirin and whether that affects stroke or not. So let's say you form two groups, a group that is, you do an observational study. So it ends up in your observation study, there's an older group and a younger group. And it happens that the younger group so the younger group is the group that is on, that is not on aspirin, and the older group is the group that is on aspirin. Okay, and then you observe that being on aspirin is not associated with a reduction of stroke. Do you have a problem with this?
Yes.
Why?
For sure. Because there is confounding, which
Yes.
is the age.
Yes,
And
exactly.
the health status. The older the people, they have more comorbidities and
Yes.
more heart problems, so hence aspirin.
Okay, so let's forget about the other factors and let's focus on age, association with being or not being on aspirin, and having a stroke. So the group that is older and that is on aspirin, are they more likely to get stroke just because they are older, yes or no?
Yes.
Yes. So they are more likely to get stroke, and then even if aspirin did not show that is preventing stroke, maybe they already had a high risk of stroke, and aspirin reduced the risk of stroke, but because they started with a higher risk, it looks like there is no association. So in this,
not a confounder.
بلا, so age is a confounder. لا هلا effect modification وصل له. So age is a confounder because it confounded the relationship. It made it appear as if aspirin had no effect. Because already they were at high risk. Even if aspirin was reducing the risk, it did not show up because the age was confounding the relationship. Okay. هلا what do we do with confounders? So if you do a trial مش رح يكون بس في, so as May said, it's not just the age, رح يكون في diabetes, رح يكون في AFib, رح يكون في hypertension. All of these can confound the relationship. So what randomization does, when you randomize, you form two groups that are, just by randomization, that are similar in terms of all the confounders. So you make the confounders equal in the two groups.
And you're not aware of who is where.
لأنه just by randomization, you make sure that those factors are equally distributed. So any difference you see in the outcomes between the two groups can only be blamed on the one factor that is different between the two groups, which is the intervention versus the control. So that's kind of the concept of a randomized trial. You make all these confounding factors equally distributed. So if you observe any difference, you cannot say, oh, I'm not sure whether it's the matches in the pocket or the age that is older. And as Iman said, it's not just the factors that we are aware of, it's also the factors that we are not aware of. So 60 years ago, people had no idea that smoking increased the risk of stroke. مظبوط? So if you are not aware of this, if you decide to do an observation study, you would adjust for everything except for smoking because you're not suspected. So you're missing on things that should have been adjusted for. So this is kind of the residual confounding that you did not take into account. But even today, when we know that smoking does affect stroke, that we know that there are other factors we're still not aware of. They might be genetics, there might be pollution, there might be whatever. So what the randomization does, it makes all the confounding factors, whether we are aware of or not aware of, equally distributed, which makes us more comfortable at, instead of talking about association, we talk about causality. That aspirin is reducing the risk of stroke if that's the result. Deb, why are we doing all this introduction? To say that not every time there's a randomized trial, it's a guaranteed elimination of the risk of bias related to this selection problem. لأنه the randomization should be done in a specific way. So, how do you ensure that adequate randomization is done? There are two things you need to do. You have to come up with a sequence, random sequence, and then do the allocation concealment. So, what is sequence generation? It is when you come up with a random sequence of numbers you use to allocate patients. So you could do this by flip of coin, or you go to Excel sheet, you say, give me a list of random numbers. You go to randomization.com, it gives you a list of random numbers. There are different ways, and then you come up with the list. Okay, so you come up with a list, so then when the patients come into the trial, you could say, okay, you are an odd number, you go to this arm, you're an even number, you go to that other arm. Okay, so that's coming up with the sequence, with the sequence generation. Is that enough? Okay, I'm giving the answer, so that's not enough. It's not enough because you need to do the other part of the process, which is the allocation concealment. So what is allocation concealment?
It's related to blinding, not the blinding of the people who are randomizing. You shouldn't be aware that I'm giving the patient this, the placebo, for example.
Yes.
Or the
Okay.
Investigators,
yes.
Patients.
لا هلا مرسل. It's the patient. It's about the person who's recruiting the patient to the trial, not being aware of what the next allocation is. And I'll give you an example.
They don't know the sequence of the randomization.
Yes.
Recruiters.
Yes. So I'll tell you the. لا هلا وصلي. So Iman is sitting in her clinic and she's recruiting patients into a trial of aspirin versus no aspirin to assess the effect on stroke. And someone gave her the list of random numbers, and she knows that the next patient is an odd number, should go into the placebo group or the no aspirin group. And let's say Iman in her mind, aspirin we know that it might be effective, but let's say at this point in time we don't know, but she suspects no aspirin might be effective. So if in the door comes in a patient who is sicker because the patient is older, she has diabetes, she has hypertension, and she looks at the allocation, and that patient should not go to should be going to the no aspirin group. what might happen is that she feels bad for this patient just because she believes that that medication is effective. What could you do, Iman?
Not put them on the trial.
Hey, so she might say, I'm not going to recruit that patient on the trial. What she could do, she could
Or recruit him after the other patient. for
Exactly.
أو
example.
تعملي لعبة
change.
أو كذا, because you know what the sequence, because you are aware of what the next allocation is. بتعملي لعبة, either you skip, you go to the next number, بتقولي مرة الجاية the next patient برجع بطلع بخلص الsequence, etc. But imagine that, okay, you don't want to do anything that is messy, يعني ما بدك زعبرة, okay? You say, okay, I'm not gonna do anything that is kind of fraud and زعبر بالnumbers. What I'm gonna do, this patient is sick. I don't want to recruit that patient to trial because she's gonna end up on no aspirin. You skip that patient.
I skip, exactly, not recruit them,
Yes.
give them aspirin.
Okay, so what would happen? So every time a sick patient comes in and was destined to go to the comparator, that patient is not recruited. But every time a patient that is sick and is destined to go into the aspirin arm, you will recruit them.
inflating the effect of it.
بعد ما وصلنا على الeffect, how would those two groups end up?
They will not
Conf-
be matched.
difference in severity.
Hey,
Yeah.
يعني
Severity of the disease.
Selection bias.
because you are deciding who goes into each arm, those who end up in the aspirin arm will end up being sicker. يعني without any bad intentions, just because you care for your patient. So
So their baseline risk of disease
Yes.
is already high.
So with that, eventually, so you see that already we have the confounding balance is lost. And what could happen to the effect of aspirin? Underestimated or overestimated or not affected?
For the sick group, underestimated.
ما في عم نحكي trial.
Overestimating.
Okay, let's do a quick vote. Who would say underestimated?
كلهم السك راحوا على الاسبرين ارم ما هيك؟
No questions. Underestimated or overestimated?
مش الإفكت تبع الدراج الأسبرين.
Yes.
You're overestimating.
Under لأنه all of the group are sick.
أي مزبوط. Yes.
ساعتها ما عم بس حسب هو شو.
لأنه the relative
severity for primary prevention.
يعني الابسوليوت ريسك ريدكشن
مش انه يعني you are underestimating لانه you are giving aspirin to a group that is sicker. يعني حتى لو الاسبرين بيشتغل they are sicker.
Oh, they need it.
They will have more events just because they are sicker. يعني حتى if you are reducing the events, they might not end up being less than the other group.
The benefits of aspirin.
Yes. طيب. So how to prevent this? يعني نحن إيمان جبنا لها a random list, عملنا the first part بس ما عملنا the second part. The second part is crucial. So allocation concealment is when you ensure that the person who is recruiting into the trial is not aware of the next allocation.
So you don't know the sequence of the sequence
Yes.
generation. I don't.
So how do you do this?
You can do the permuted block مثلا.
The permuted block has a different purpose.
Yeah. So once
نعيون.
Permuted block, the purpose is to ensure if you have allocation concealment, it ensures
So I
ensures
don't
balance.
have the list. The person who's recruiting into the trial
don't have
doesn't have
access
the
to
list
the
of
list.
the
So what do we call this?
allocation concealment.
Hey, لا بس انت the procedure you are describing that's called central allocation.
Right.
So you as an investigator, the patient comes in, you assess them for eligibility. You have no idea what the next allocation is. You say this patient is eligible, you consent them to participate, and then you call and say, I have a patient that is in, this is the consent form, all is done, we cannot go back, and they will tell you where the patient would go if it's not blinded.
The best is to use systems that are automated, web.
ما هي نفس الشيء.
Central.
بتصير
آه.
central.
لأنه
This is
الأنف- they
central.
used to do envelopes right بس
Okay.
envelopes you
envelopes
can
is
also
يعني فيها بلسر يعني فيها
لك وين هون. So قلنا sequence generation is easy. You know the Excel sheet, the roll of dice. Allocation concealment, either center randomization office. They do them in a lot in the multi-center trials. Pre-number or coded containers. So you are sitting there in your clinic and you have containers of the medication. They are sequentially coded, so you have to go one after the other, and you don't know whether it's the active medication or the placebo. Nice, you like it, Sheikh? Or the other one is sequentially number sealed opaque envelope. So this is where it's envelopes and they are numbered, so you have to go by number. Sealed, you cannot open them and look. That was عليهم. I know you do it, Iman. And opaque. So ليه opaque؟ لأنه so mentioning Iman لأنه it's an anecdote. So when they were doing the trial comparing open appendectomy versus laparoscopic appendectomy, this is when the laparoscopic technique was coming out. They wanted to do the trial, compare which one is better. The residents at night, they were told that if you have to do an open appendectomy, you don't have to call the surgeons. You can take the patient to the OR and do it yourself. However, if it's laparoscopic, because it's a new technique, you have to call the attending for the attending to come in. So imagine a surgical resident calling their surgeon at 2 a.m. You have to come in. So what they did to avoid the situation, they would have the patient and they have this, the envelope. So they would go to the next envelope because it's sequentially numbered, and they would put it in front of the light to check whether it's gonna be which arm. So if the patient is gonna have the laparoscopic, they would not enter the patient into the trial. They would enter the patient only if the patient is, it's randomized to the open. So if coming at night is associated with, there's a confounding factor, I know they are sicker, or whatever, so that would lead to bias. So anyway, since then there have been lots of question marks about these envelopes, so they say they have to be opaque, but it's probably better to skip them and go with the central randomization. Ajad, into surgeons.
Usually, Dr. Bas, is in case the paper, they use the seal envelopes, I would give them, in this case, for allocation concealment, like a moderate bias.
هلا بنوصل له.
Provided is a
surgeon trial.
No, if it is mentioned that this is, I mean, you have to trust them. If it's mentioned in the paper, خلاص, you respect that.
But in general, lack of allocation concealment, they've done studies. So how do we know that allocation or lack of allocation concealment introduces bias? So they have done studies where they look at trials looking at the same clinical question, okay, trying to answer the same question and compare those that had allocation concealment and those that did not have allocation concealment, and pool the results. Those that did not have allocation concealment overestimated the effect. So this is an indicator of lack of allocation concealment introducing bias.
But sometimes what happens is you cannot conceal. Now I can think of any example.
Yeah.
Like, it's obvious that this patient is being in the experimental group and some other patients are not. So
like
how
what?
do you grade? I can think of any example.
So I think you're thinking more about blinding.
Blinding.
So blinding might be hard to blind.
Side
The
effects.
treatment.
So تنقول حدا you have knee pain, you do surgical treatment or medical management. You cannot blind. However, when you allocate, it's an allocation.
Okay.
You can send the patient central randomization. They tell you this patient ends up in medical management versus surgical management. It's doable.
Yeah.
Sometimes there is a side effect that is common to one
And you
arm.
catch it.
Metallic taste of whatever medication.
Yeah.
But that's blinding. We'll get to
We
blinding.
need many times we need the randomized trial and they do not mention anything about allocation.
Okay, so when they did that study I mentioned,
Unclear, but
when they did that study, they grouped the when it was clear that there was no allocation concealment, and the lack of mention whether there's allocation concealment. These were one group. They compared them to studies where there is allocation concealment.
Total voting, yes versus abstain and no.
But is there I cannot recall that I read an article that mentioned no allocation concealment.
لا ما في.
ما في
ما
لا
بيقولوا.
they just forget about it.
Something you extract from the text. بس في شغلة بس إذا واحد عم يقول web based بيقولوا خلص دغري بعتبرها إنه central randomization.
مش ضروري. If they don't say central, so web-based, it could be there's a website called randomization.com.
For sequence generation, the permuted blocks or
Aye.
simple randomization.
So it's still missing.
So they have to be explicit about how they did it in the central
It's
randomization.
described.
Pre-numbered or applicable.
Mm.
Most of the studies we read says randomized patients.
They don't provide the details. That's not enough. So the randomized could be they just had the random sequence and there was no allocation concealment. So that's not a guarantee.
Like on review, I'm supposed to ask.
So, and if you are a trialist, you would, and if you did it right, you would,
Be
you
proud
would,
to mention.
yeah, and you would mention that this is how we did it. If you made the effort to make it, the coded containers, or so. Mona, you've done
You
this
would
check, so
describe
with the
it,
trials.
In our trials, we
بالتبعوا للانتيبايريتكس what we did is that once the sequence was generated هلا ما بتذكر مين بالFHS عملها it was kept with the pharmacist. So when we recruit somebody after getting the informed consent we will call them or the RA would go down with the paper المكتوب عليها الويت وكل شيء ورقم الأوضة etc. and the information تعطيها للpharmacist and then they send us the drug. So this is typically concealed allocation.
So this is allocation concealment. So this happens at the beginning of the trial بعد ما في blinding ولا شيء. And again, the purpose is to ensure that we have two balanced groups in terms of prognostic factors. هلا everything that comes later, like blinding and everything else, is to ensure that this balance is kept, is maintained. Okay, so question: who do you blind and why do you blind them? Okay, who let's start. Who can you blind? So the patients. So why do we blind patients?
Outcome reporting. Outcome reporting. Right?
Okay, so first outcome reporting. So if the patient is randomized وقالوا له أنت you are randomized ما طلع لك aspirin بتطلع لك مشي. So that patient will be upset. راسي عم يوجع. Do you have headache? Yes. Quality of life bad. So the subjective outcomes are going to be reported in a more negative way لأنه it's subjective. So that will affect the assessment of subjective outcomes. وفي performance bias, which is what? لا بعدنا. So what could happen if the patient knows or is aware that they are not getting aspirin?
Contamination.
More towards pain, for example.
Hey.
The case is not aspirin, and aspirin maybe you have indicators, you have symptoms. Whereas for pain, he might report higher pain.
Yeah, that's the point. Yeah, subjective outcome are more likely. They are more likely to be affected.
They reach out to get another medication.
Yes. So
contamination.
if they are aware of that they are not getting aspirin, they might go and take aspirin without telling the investigators. لأنه سمعوا إنه ولا الأسبرين might help. When I'm not on aspirin, they will go and take it and not tell the investigators. So what would happen if, everyone who's not on aspirin ends up taking aspirin in terms of the effect estimate?
Extreme
It will not
scenario.
do well.
Hey, the extreme scenario. What would be what?
They will be equal. They will be
Diminished.
Hey, there will be no effect. The effect estimate will be a relative risk of 1. لأنه both arms are the same in terms of everything. So even if they don't take aspirin, they might go and exercise more, or they might go and to have a better diet, etc.
All the outcomes.
Hey, so that's called the performance bias. The way they perform is going to be different. Okay, who else besides the patient do we? Okay, the investigators. So the investigator is the same. So investigators, if I believe that aspirin is the thing to give to my patient, and I know that my patient is not on aspirin, so what I could do is, either
Not put them on the trial.
لا بس هيدي allocation concealment. The patient is in the trial.
Right.
So if I'm not blinded, I might go and I might prescribe Plavix. لأنه like
I see.
or I might be more aggressive with treating the risk factors like hypertension, diabetes. Or I might be more insisting of you should go and exercise, you should go and should improve your diet. So there's now it's co-interventions that are not applied equally in the two arms. Just because
كله is
it could be both. And sometimes it could be unconsciously or sometimes consciously. لأنه it's not because you want to mess up the results, it's because you're trying to be a good clinician.
Yeah.
but you end up messing up the study.
Yeah.
But if you're concealed already, so you are blinded من الأول يعني.
لا ما خلص.
ما هيدا قصدي كيف
في randomization treatment في بعد blinding على analysis level. So at different stages. No, this is at the treatment level.
يعني
اجى الدواء بس
بس
مين المفروض ما يكون يعرف شو هو الدواء؟
ما انت عارفه
انت
مثلا
رح تطلعي بأي جروب بده يطلع.
ما عرفت اذا
يعني allocation concealment is to randomize. خلصت allocation concealment, the trial could be blinded or not blinded.
يعني it has continued. The blinding has to continue.
اوكي حتى الآن يمكن يكون من الأول منهم blinded ما عندهم كان concealment مثلا
لا
أو شيء.
خديها في you can start with a trial that is not concealed بس تكون blinded بعدين.
ما هيدا قصدي انه فيها تكمل blinded بس already ما كانت
أي.
concealed. وإذا كانت concealed
فيها تكفي not blinded. These are different processes. The blinding is the process at the time of the allocation. Is the person is aware of where the patient is going and whether that is affecting the entering the patient into the trial or not. ويمكن يكون a different person recruiting and then there's the provider.
Sometimes the investigator ما بيكون من the recruiters.
Yeah, it could be. So these are different issues.
Still on that one receiving the treatment come in, he should be also blind.
So these are different issues. So the allocation concealment is it's about creating equally balanced groups. هذه الcreation. And then the blinding is what happens from this point on to preserve the balance. ليه؟ لأنه مثل ما قلنا lack of blinding, the patient will go and take aspirin, will do this, will do that, so the balance is going away. So that happens later on. So حكينا عن blinding of the patient لأنه معقول يتصرفوا بغير طريقة وياخذوا أشياء or the way they report the outcomes. نفس الشيء with the physicians because they might treat the patients differently. Outcome assessors, so data collectors and outcomes assessors. So there are outcomes that are where you need a judgment. So for example, resolution, regression of the tumor. So sometimes, and they've done studies, if they give the same X-ray to two different radiologists, they might give you, we know this, they might give you different results. Is there a stroke on the CAT scan? This might be a stroke or not. Is there, a small bleed? So these judgments can vary. And knowing what the allocation is, and if you are biased, consciously or unconsciously, in favor of the intervention or not, you might give different answers. So for example, a heart attack, which is you think that this is an objective outcome. So how is a heart attack, myocardial infarction judged? How do we judge whether a patient had a myocardial infarction?
Yeah, the EKG.
So we take EKG, labs, or symptoms. So what happens in the trial, the patient is giving aspirin, and then at the end, there's an adjudication committee that looks at the file, and they need to make a judgment whether the patient had a heart attack or not. نعم.
We jump from performance. outcome assessment.
هلا هو detection.
but this is عشان احنا كنا بالperformance نقلنا دغري على detection.
اوكي كان لازم نقول عملنا. Next time.
So yeah, you are right. This is sometimes detection bias.
عم نحكي على detection bias. So the way you assess whether the patient had a heart attack, you look at the symptoms. And if I'm biased, I could interpret this. So this is atypical pain. So someone had atypical pain. I would say, yes, this is in favor, or maybe this is not in favor. An EKG finding might be borderline. I might say this is yes, positive, this is negative. And even enzymes could be borderline. And depending on if I'm biased, if I'm not blinded, and if I'm biased, I might judge these factors that you would think are very objective in different ways. So that's why those who are adjudicating the outcome should be blinded. The lack of blinding doesn't necessarily mean that there is bias. So if the outcome is mortality, would lack of blinding of the outcome assessor introduce bias? Probably not. And if someone is dead, usually they are dead. There have been unusual cases. So this is an objective outcome where the lack of blinding is not an issue, as opposed to more subjective. I wouldn't say subjective. The outcomes where you need a judgment. So lack of blinding is not necessarily an indication of bias. It depends on the nature of the outcome. So this is the list of who could be or should be blinded. The patients, because the patients could report the outcomes subjectively because they could go and do other things. Same with the providers. So data collectors, those who are collecting the data, outcome adjudicators, sometimes the data analysts, because we know that the same data, you could analyze it in different ways. And sometimes you could, like they say, if you torture the data enough, it will confess. It will confess. So you keep doing, you keep doing kind of acrobacies in terms of the statistical analysis until you get the result. However, if you are blinded, they tell you this is arm 1, arm 2. They don't tell you which one the aspirin. You just do one analysis, the best analysis, and then you will give the result. Okay, so these so far, we're still talking about the individual study, and these factors could be introducing bias, which is systematic deviation from the truth. This is the next one, which is missing data. So can patient with missing outcome data introduce bias? This is the kind of question where the answer is very clear. It's yes.
Because it depends.
And the question, how do you assess? So I'll give you an example just to, if we turn off the lights, could you still, yeah? Because that might help us. We're okay? Okay, so look at this. So this is hypothetical data just to make the case. So you have 200 patients randomized into aspirin and no aspirin. And you end up with 10 events, let's say mortality in one arm and in the other arm, and one missing data. So what's the risk reduction between aspirin and placebo? So what's the risk of death in aspirin group?
10%.
So 10%, 10 divided by 100. And in the placebo group, 20%. So the we'll get to plus or minus 1. So what's this? Yes, so forget about the 1. Yes, that's a good point. We'll forget about the 1. What's the relative risk of mortality when taking aspirin?
0.5.
0.5. So 10% divided by 20%. If I tell you there's missing data, 1 in each arm, are you concerned that this number will be much different?
No.
Probably not. Okay, compared to this. So same 200, 100, 100 in each arm. Now, same 10 events and 20 events. So if you disregard the missing data, you have 50% and 10% and 20%. But now you have 20 missing data, 20 participants with missing data. So simple question, are you more concerned than the first scenario?
Yes.
Less concerned? More concerned. لأنه if just imagine that out of the 20 missing in the first arm, 10 had events. Okay, what do you end up with in terms of 20 by 21? Okay, and if we have this high number of missing data, then there's a risk that the results might change. There might have been bias introduced as opposed to the first scenario. Okay, let me give you a different scenario.
This is even more dangerous.
Okay, so now what is the relative risk in this study?
Without the missing data?
Without the missing data, مظبوط. 1%, 2%, 0.5. هلا هون we have one missing data. Are you concerned?
Yes, because it is one event.
One event.
One missing data was an event.
In the first arm, in the aspirin arm.
So now you have 2 events.
2 over 2.
So
no effect.
No effect.
Okay. Okay, so based on this, when are you concerned about missing data?
Effect size.
When it's more than 20%, or more than
proportion of missing data matters.
Okay, so it used to be, can you يقولوا إنه if it's more than 20% missing data, you have to be concerned. This is 1% missing data. Are you concerned?
Yeah.
It's
Because
just
of the events.
Rare events.
You have more than
حسب events, exactly.
Okay, so it is, the number of factors.
Because if it is differential, يعني in one arm, you have more missing data in one arm as opposed to the other.
So a number of factors can affect. It's first, أكيد, the higher the percentage of missing data, like in this one, the more concerned you are. But in this one, it's kind of the ratio, if you want to call it the ratio of missing data to events. So the less events you have, the closer the number of missing data to events, the riskier it is. So remember that missing data, we have no idea what happened to them. And what you do is start speculating. And in this one, if you speculate, whatever you speculate, so assume that all of those in the aspirin arm had events and none of those in the placebo arm had events, it's still fine. It's 11 versus 20. I'm not concerned.
So the risk reduction, if the risk reduction was small, then the missing data will affect. If the risk reduction
هون كله it's 50%. هلا the smaller it is, the higher, the riskier it is to lose significance, if you want to think this way. But it's about both the percentage of missing data. But it's not just, so this 20% thing is wrong. You should not use the 20%. You have to look at, if you are looking at the trial, what you have to do is look at the number of events and look at the number of missing data and do some simulations. There are formal ways where you could do the simulations, but sometimes it's very easy. You look at the event rate, it's 1%, and you have 5% missing data. So this is huge. And I'll tell you, I have no trust in that trial, whatever the result is, because, you know, with any simulation, you would lose statistical significance. Non-adherence. So this is important because many people confuse non-adherence with missing data, and ITT with missing data. Hey. Okay, so there's a difference. So what is non-adherence? Non-adherence is when someone is randomized to one arm and then is somehow crosses over to the other arm. They decide to stop taking the aspirin, they decide to start taking crossover. It's non-adherence. So this is the example. Okay, so first some definitions. So how do you deal with non-adherence? There are different ways. Any guess about what those mean?
So intent to treat.
Intention to treat is
As
actually
randomized, as analyzed.
Yes.
whatever happens if they stop
In
the
Vegas.
drug, if they don't stop, we're going to calculate the effect as
is.
As is.
So however they were randomized, you analyze them. Okay, what about as treated?
Depending on the treatment they took. So if
The
they're in the
actual
placebo,
treatment.
Yeah.
actual treatment received, yes.
Yes. So if someone was supposed to be on no aspirin and ends up taking aspirin,
So we add them with the aspirin on.
yes, and per protocol,
According to the
It's
original
only the ones who are
protocols.
compliant with the
So
protocol.
we
Yes.
cancel the.
And you exclude
So you
the
exclude
others.
them.
We exclude them.
okay. So analyze all those randomized in the arm to which they were randomized, irrespective of adherence. That's intention to treat, ITT. As treated, you randomize, you analyze all those randomized according to what they actually received, and the other one depending on whether they were adherent or not. So let's do an example. Okay, so thanks. So this is a similar example. So here we have no missing data. It's just that in the aspirin arm there were 20 non-adherents. They decided to stop taking aspirin, and among those we had 10 events. The 80 that are left, or they were still adherent, we had 10 events, and in placebo arm we had 20 events. So under ITT, how we would analyze those?
20% over 20%.
Yeah, so we would add this 20 out of 100, 20%, divide by 20 over 100, which is 20%. 1. Okay. Per protocol, what would we do with this if we do per protocol?
We just exclude them.
They were not adherent, we don't
10
analyze
out of
them.
80.
So 10 out of 8.
Yeah, so we do 10 out of 80 divided
Over
by 20.
20%.
Okay. So what do we get? 0.63. Okay, now as treated, what do we do with these?
Only we
Add
have
them to the
add them.
placebo.
يعني 20 البلاسيبو بصير 120 و 30 event.
So 30 and 10 plus 20, 30 divided by,
out of 120.
120. And
only 10 over
10
80.
over 80.
0.5.
بس البروتوكول انه عشان اذا
As treated.
ايه يعني بيكون لا سوري as treated بيكونوا they receive 20 يعني بتحسبوا البلاسيبو مع النون adherent
The non-adherent, so it's all about the non-adherent. What do you do with the non-adherent? Under the as treated, you take the non-adherent and you analyze them based on whatever they got. In this case, they did not take aspirin. You analyze them as if they were on placebo.
120
Yes.
oh that's what we do 20
Yes. What you observe is that with the same data, and depending on the way you analyze them, you end up with different results. يعني here with in ITT you have no effect. شوي with as treated it's 50% reduction, which is huge.
Which one do you pick?
Yes, that's the question. So the first message is that there is actually difference between these, and not all of them could be reflecting the truth. يعني في واحدة صح، في واحدة غلط.
ITT preserved the randomization to start with
Yes.
sample size
Just you know there's something
Yes.
wrong.
And it reflects the real life scenario.
effectively. بينما ال per protocol you disturb the randomization and the sample size لأنه you excluded patients, so the study lost the power.
There's closer to the
Sometimes.
Which one?
truth.
Per protocol. Okay, so let's discuss this.
But you're removing patients that can worsen the randomization.
Yes. So the first problem with per protocol, let's forget about S3. Let's compare per protocol to ITT. So per protocol, what you are doing, you are removing patients from one arm and just removing them, and this could affect the balance. لأنه typically those who are non-adherent are not similar to those who are adherent in terms of characteristics. So they tend to be sicker, لأنه non-compliant, maybe they're sicker, maybe they had bleeding, maybe they had worse outcomes. So what you are doing, you are breaking the randomization, and then this is introducing bias. The other point that was mentioned is that in real life, what will happen is that when you randomize individuals, those 20 will not be identified as in few months they will be non-adherent. So in real life, those patients will get aspirin, and in real life they will stop taking aspirin, and in real life they will get the 10 events. So if you want to think about what will happen in real life, and if you want to reflect, if you tell the patient what would happen to you in real life if you take aspirin versus no aspirin, in real life I will give you the medication. There's a 20% chance you will stop taking it, but at the same time there's a chance that your group will get 10 events. So what will happen in real life is actually keeping the analysis as is. So keeping the 20 who are non-adherent with those who are adherent in the analysis. Intention to treat. لأنه هلا we cannot tell at the time of randomization who is going to be compliant, who is not going to be compliant. So for that patient, I'm starting on aspirin. If I want to tell them what is likely to happen, I have no idea which one of them will be the 20 non-adherent. So in order to give them the expectation of what could happen, I have to analyze those together, adherent and non-adherent, and the other arm together. So this is what Muna was referring to. This is real life analysis, what would happen in real life. So that's why ITT is always the better option. And because we know that one of them is not correct, we tend to go with ITT.
And that's why the randomized phase 3 trial are called effectiveness, not only efficacy. So it is phase 2 are efficacy.
Yeah.
But what about as treated? Because, if the individual got aspirin and then the effect was whatever is the effect, this is like a real life too, right? Like those individuals who are not adherent and they got aspirin eventually. It is.
But so first there's the problem with the breaking the balance. The balance of randomization, but still those as treated, when the patient will come and ask you, what should I expect from this medication, until you don't know how they will eventually behave. You only know that as a group, if they take aspirin versus they don't take aspirin, this is what will happen. And those who are non-adherent, they are non-adherent for good reasons. Maybe they had a bleeding from aspirin. So you cannot say, okay, you had a bleeding from aspirin and then you're not taking aspirin anymore, I would randomize you with the non-aspirin group. They should still be with the aspirin group because the reason they bled and maybe they died eventually is because they were taking aspirin. So why should I analyze them as not taking aspirin? So it's a bit of tricky issue. هلا per protocol, so في ناس بيقولوا ITT is what you expect overall. Per protocol is what you expect if the patient is compliant. So I would tell the patient, overall there's no effect. However, if you are compliant, you expect a reduction of 0.63. So some people interpret it this way, which might make sense. But again, there's a problem with
the problem of balance.
The balance.
usually randomized trial, most of them they report both. ما هيك بيحطوا ال ITT.
No, not everybody. Some would do both.
هلا إذا كانت non-inferiority study, they have to report two types of analysis. ما هيك it is a must.
Yeah. هلا the protocol
is a preferred one, I guess.
Right.
And it should be confirmed by the ITT.
Yes, they do both. بدهم يحطوا اثنين ما بكفي واحد بالnon-inferiority.
So there's a special issue with non-inferiority that we could discuss separately. But I wanted to mention, sometimes as treated is used for side effects. لأنه with side effects, if a side effect is very specific to a certain medication, we'd say that this is our best estimate. So this is a bit more acceptable.
So it depends on what you're really measuring. If you're using a medication, okay, the real life is the ITT, that's probably going to give you a closer look to what's going to really happen in real life. But for example, if smoking against non-smoking, you really
ITT is more for intervention trials. So, So if you are, so it's a separate issue if you're talking about associations and risk factors. Yeah.
We will have to decide what
So نحن هون
Intervention.
yeah, this is relevant to intervention.
We do not test a bad intervention.
But that's exposure in that case. You know, if you're doing like observation study.
Observation.
طيب stopping study early for benefit. Okay, yeah, thanks for coming.
Thank you for this.
So stopping study early for benefit. So you might it's become popular in major journals to say there was this trial where we planned to recruit 10,000 participants. But then when we did the interim analysis at 5,000, we found a very large effect, and then we stopped the trial. And this is, and this is like editorial, and, this is like the big discovery. This is large effect, even before we got to the sample size calculated. But this by itself is believed to introduce bias, and I'll show you the example. So this is a trial that actually was not stopped early, but they did a number of interim analyses, meaning that after every X number of patients recruited, they did an analysis to look at the results. So they were having a peek at the result. And this is a study comparing five versus 4 courses of chemotherapy, I think, in patients with acute myeloid leukemia. So after they recruited about 200 participants, I did the analysis, and there was a statistically significant result. This is 57% reduction. And then after they recruited this number of participants, this is the effect estimate. And be careful, this is not a meta-analysis. It's the same trial where we are showing the effect estimate in
different sample sizes.
Yes, in increasing sample sizes. So this is what they found.
Closer to the mean.
So after they recruited a large number of participants, the initial observed effect estimate went away. It's not statistically significant anymore.
No, it's crossed the line.
Yes. So what do we call this phenomenon? Regression to the mean. Sure. So that's called regression to the mean.
Yeah.
Because with smaller trials, you are likely to have large effects that are not correct. So the example that I always give is the example of flipping the coin. So if you take a coin, and what is the truth about flipping the coin? What should you get in terms of 50 tails, 50 heads? So if you do it 10 times, you expect 5 and 5. Do you expect to get, if you do a trial, do you expect to have 6 and 4? Would it be reasonable to get 6 and 4? Easily. Could you get 7 and 3?
Yeah.
Yes.
Come in relatively easily. Could you get 8 and 2?
Yes.
Might happen, maybe not as frequent. What about 9 and 1?
Yes.
Less frequent, but it could still happen. Because حتى 10 and 0 could happen. So now if you do it 100 times, could you get 60 and 40?
Yes.
Yes, but it's less likely to happen than 6 and 4. Could you get 70 and 30? صعبة. It could happen. أصعب من 7 and 3. Now, if you do it million times, is it easy to? Would you expect to get 600,000, 400,000?
Expect 50.
No way. But you could easily say 4 and 6 أكيد. And 4 and 6, you're not surprised. Why? Because with small trial, there's lots of play of chance. Because with small trials and a small number of participants in this case, the play of chance is more likely to happen, and you wouldn't be surprised. So that's called the regression to the mean. So let's say you flip it, and that just by chance you get the all 10 and 0, which could happen easily, 10 and 0, or 9 and 1. With more trials, it will eventually, when you get closer to 100, when you get closer to 100 to 1,000, it will get closer to 0.5. لأنه أول شيء ثائبت بس ما فيها تضل ثائب. So eventually, with higher number of participants or trials in the case of flipping a coin, you regress to the mean. In the case of flipping the coin, we know that the mean is 50-50. In the case of a trial, we don't know what the truth is. And if I get this, when I get this with small number of participants, I don't know whether this is the true effect or not. It could be that if you keep doing this, the truth will be here, or the truth will be here. We don't know. But what I know is that this is a small number of trials, and this is exactly why we do a sample size calculation. What is a sample size calculation? It's the minimum, it's the number of participants in the trial that is large enough that if I get a statistically significant result based on my formula, it could not be due to chance. It could be due to chance with the alpha, which is 5%, for example. But this is the idea behind a sample size calculation. It's the number of participants that will allow me to prevent the findings that are falsely positive just due to chance. Yani flipping a coin, I can tell you that the sample size needed is it's not 10. It should be more than 10. It's not million, بس ما بعرف, it could be maybe 100 or 1,000 or 500. So you do the sample size calculation. المهم, when you do the sample size calculation in a trial, you choose an outcome, which is the primary outcome, for which you do the sample size calculation, which means that for that outcome, if you get a statistically significant result, is that if you've recruited all these patients based on sample size, exactly. It's not due to the chance, هيك لأنه it would have been due to a true effect لأنه regression to the mean would have happened at that point.
When you do the sample size calculation, you would know that يعني ما بتسمح حالك تصير regression to the mean.
لا, the sample size calculation is where
assure
to
that.
لا.
To assure that you got this.
Yeah, but I mean not that you cross the line of no effort.
ما بعرف شو truth. It's based on.
It's a negative study.
هلا أنت when you do the sample size calculation, what you use in the formula is a given relative risk and a given baseline risk. So you are assuming that if I find this relative risk, it would not be due to chance. It would not be the 6, 7, and 3.
But then if the trials, the first two trials, let's say...
This is the same trial.
Yeah, no, I know. But then if you, for example, your population size has been big enough and then you stop it at an earlier stage, there is no more kind of bias in that sense.
Okay,
Because
so,
you have a better kind of
yes.
estimate of the...
What you're talking about stopping early in terms of follow-up.
Yeah.
So here stopping early refers to stopping early relative to the number of participants recruited. That relative to the, and they always do the follow-up that they had planned for in terms of time follow-up, but they stopped recruiting at, يعني مثل كأنه they started flipping a coin, they got 9 and 1, and they said, okay, we got it, we stopped this trial early, flipping a coin is 9 and 1. So this is what happens.
Yeah,
So that's,
is it a bad thing?
it is, it puts you at risk of bias. The truth might be, okay, the truth might be that this is the truth. Okay, this might be the truth. I don't know. This might, يعني, this is that the truth is a 50% reduction. إذا بلشت flipping, إذا بلشت أعمل trial, it might start with 50% reduction وتبقى 50% reduction. يمكن تبلش 10% reduction وتنتهي 50% reduction. يمكن تبلش 90% reduction بس تنتهي 50% reduction. I don't know. What I know إنه to get to a stable, إذا بدك, the number I am confident in, a reliable number, I need a minimum of this number of participants, لأنه whatever result I find, I would be sure it's not due to chance. Okay, so this is the rule of small numbers. Whenever you have small numbers, there's a play of chance. The chance can mess up your result. So I'm not saying that if they stop early and there's a benefit of 50%, that there's definitely a bias. I know it might be that it's 50%, but I don't know. I'm just saying, they stopped it too early. I'm not sure that it was going to regress to no effect, or it was going to stay as 50%.
Or regression to the mean is a good thing.
The regression to the mean, it's a good thing.
And when you increase the sample
Yes.
size and to reach.
Yes. So that's why when a study is stopped early for benefit, there's a concern about the validity of the results.
So if that applies to benefit, would that apply also to
Harm.
Right.
Yes.
Same
Sometimes you
concept.
stop because of excessive harm.
Same
So
principle.
if it's a bad thing to stop because there's very good benefits.
Aye.
should we
So this typically applies to benefits. يعني then, so the group at McMaster ran ran the studies showing that this happens, but it was restricted to benefits, because when you stop due to harm, typically the harm is specific to a certain intervention. يعني mortality could be due to anything, But if you harm that is specific to a certain intervention, you are, this is less likely to be misleading.
What if
The
in the
HRT,
study
hormone replacement therapy study.
It could be, it could be. But this typically applies to benefits. I get your point. So you could have the same phenomenon when you look at harms, yes. Type. So far, we've been looking at factors that decrease our confidence, and this is what we covered. We covered this. So all of these are introducing bias into the result of the individual trial, okay? And we went over this, and when you have a risk of bias in the study, you are less likely to believe the overall result when you do a meta-analysis across studies. So you do this risk of bias for each study, and then if all the studies are at risk of bias, then the pooled effect estimate, you have less confidence in it. If all of them are at low risk of bias because they dealt with this appropriately, you have more confidence in that pooled effect estimate. And most of the time it's a mix, so you have to make a judgment. However, we're still talking at the level of the individual trial. There are factors across the trials that might affect our confidence, meaning that even if all of this is perfectly done, so you could imagine a meta-analysis where all of this is perfectly done, but then you get to this. So these are two scenarios. Assume that this is looking at the same question, which is not, but just assume that this is looking at the same question, and assume that there is no risk of bias. So the individual studies are totally fine, and these are the individual studies that are listed, and we are plotting the results. What is the major difference between the two? Again, keeping in mind that this is not the same question, but a quick observation, what is the difference between the two graphs that you could? Yes. So if you start with the second meta-analysis, you have studies showing benefits on one factor, on the other studies showing harm. You could always pool the results. So if you look at the pooled results, the relative risk of odds ratio of 1, which means in this case there is no association. Do you feel confident about this conclusion? No, because it's a few studies are saying that there's a negative association. Exactly. So it could be that those studies are done in adults, those studies are done in children, those studies are done in high-income countries, those studies are done in low-income countries. There might be a factor that actually explains this heterogeneity, and it simply doesn't make sense to say that overall the effect estimate is 1.
83%.
يعني كأنه نعمل average لشيء that is we should not average لأنه because of the inconsistency. So I-square 83%, high heterogeneity. In the first case, if you look at the results, they are consistent. And all of them tend to be close to 1. And if you look at the confidence interval, they all overlap. So they are giving you a consistent result. So I wouldn't mind to pool them. And pooling them is just trying to get the average effect estimate. And because they are consistent, I'm not worried about this. So this is called inconsistency. And again, it's irrespective of risk of bias. So the risk of bias in the individual study might be very low. And then when you plot them and you try to pool them, you find high heterogeneity. Here you stop and say, okay, do I have confidence in this 1.01? I would say I don't have much confidence. And if I end up pooling and I say the estimate of the effect of NSAIDs in this case on whatever outcome is 1, I wouldn't be that confident. So that's heterogeneity or inconsistency. So what you typically do, you assess for inconsistency, and then if there is inconsistency, you look for explanation. Okay? And in some cases, you do find an explanation. So in some cases, you find that studies, so let's go back to this, and I just give random scenarios. Let's say that the studies that show harm were done in adults, and studies that show benefit were done in children. In this case, if I'm able to explain why there's heterogeneity, I do this subgroup analysis, and I find that in adults they are protective, in pediatrics they are harmful. This is a valuable information that I would say this intervention should be done in the adults, but not in kids. So this is called a subgroup effect, and that helped me to explain the heterogeneity. And this is what we call it in classic epidemiology, we call it interaction. So we could talk about this another time. But heterogeneity, if the point is, if we cannot find the reason for heterogeneity and we still decide to pool, we downgrade our confidence in this pooled effect estimate if there is heterogeneity. Does that make sense?
Yes.
Okay. Indirectness of the evidence. So I'm trying to find out whether aspirin is effective in primary prevention. So people who had never had stroke, if I give them aspirin, would that prevent stroke or not? And I look at the studies, and all the studies have looked at secondary prevention of aspirin, meaning that those are patients who already had aspirin, who already had stroke in the past, and now we are testing whether aspirin works or not. And let's say that those studies show that in patients who already had a stroke, if you give them aspirin, there's a reduction in recurrent stroke. However, my question is not about secondary prevention, it's about primary prevention. So in this case, there might be nothing wrong about the evidence. The evidence in secondary prevention is based on perfectly done trials, so low risk of bias. All the trials have given consistent results. There's no inconsistency. The only problem is that the population where the evidence is coming from is not exactly the population of my question. But I need to answer my question. I'm not answering the question of the trials. I have a patient in front of me who had never had stroke and asked me, should I take aspirin?
Although from the start, you gather and you're doing a systematic review,
yes.
and you're
So
gathering this information. But your inclusion criteria is primary.
Okay, so let's say, exactly. So you say, I need to answer the question about primary prevention. You do a systematic review, you find 0 studies. 0 studies. And you know that on the side, there's a systematic review that was done in secondary prevention. So you have 2 options. You either say, I'm going to say there's no evidence, and say to the patient, I have no idea. Or think about this other evidence that is low risk of bias, that is consistent. However, the only problem is that it was done in a slightly different population. In that population, I have high confidence that it does reduce stroke. The question is, if I'm going to take that evidence from a slightly different population and apply it to my population, do you feel that your confidence in those results might be affected?
Yes.
Yes. You know, and there's a judgment. You might say yes, you might say no. But let's say in that case you say, you know what, I'm not, it probably applies the same, but I still have some doubts. Because we know, for example, in heart disease, ischemic heart disease, the results of aspirin have been shown to reduce recurrent ischemic heart disease, but in primary prevention it has no benefit. So now I'm thinking now about stroke. If I make this analogy now, I have doubts. Is it similar in stroke or not? So by making a judgment whether that evidence or whether that effect estimate applies to my population, I have to take into account this indirectness of the evidence. And if I feel that it might not apply similarly, I say there's indirectness of the evidence to my question. Again, it's all relative to my question. When we talk about secondary prevention, it's high quality. But when I take it and apply it to my population, there's indirectness of the evidence relative to my question. And if you make that judgment, you lower the certainty of the evidence. Again, there's nothing bad about the evidence. It's just, to your question, it's a bit indirect.
But then the confidence in the results is kind of jeopardized in this case.
Yes, because of the population.
You downgrade it.
Yes, so in this case, you downgrade the evidence. You say, this is, for me, you might say it's moderate quality evidence that there is a reduction in stroke, as opposed to saying I have high confidence that it reduces stroke. In this case, you say I have moderate confidence, or you could even say low, depends on your judgment. You say I have low confidence that it reduces stroke. So you have to make that judgment. And this is relative to the patient population, but also to intervention. So let's say this medication, aspirin, should be given 100 milligrams per day for prophylaxis. And then there is this study where they gave aspirin at 20 milligrams per day. Okay, or the other way around. So you have to make those judgments. And sometimes in the outcome. So they show that there's a reduction in mortality at 6 months, but I'm interested in 10 years. Okay, do I trust that this data related to 6 months is going to be translated or still translated into reduction at 10 years? So you make a judgment. The next factor is imprecision. So we talked about imprecision. So let me show you this example.
About confidence interval.
Yes. Again, think about this. You could have, you do your meta-analysis. I'll make assumptions. The studies are at low risk of bias. There is no inconsistency. There is no indirectness. Killo perfect. The only problem is that the confidence interval is a bit wide. So this is called imprecision, and the imprecision could affect my confidence in the result. The only thing I would like to talk about in terms of the imprecision is relative to what? So, and this is a a separate discussion. It's about clinical significance. So I might tell you that I have a medication that is so let's say the outcome of interest is so someone has a migraine and I'm looking at reduction in or resolution of migraine. Okay, and I tell you that this medication has side effects, which is severe nausea and vomiting. Okay, so I tell you what would be a clinically significant reduction in migraine, so it would make that this medication, which could also be expensive, make it worth it. So I tell you everyone who takes it will have, or 50% will have nausea, and 10% will have vomiting. And I tell you that out of 100 who take the medication and have migraine, one of them will benefit. Is this good enough? No. If I tell you all of them will benefit, that's probably good enough. If I tell you 2 or 3 will benefit,
so we have to determine the threshold.
Yeah, so there's always a threshold of clinical significance. هون حاطين 1%. Could be, it depends on the case. What is the outcome? So with mortality, you are happy with 1% reduction. With maybe with migraine, we say, but at least 5% reduction. Depends on the outcome. It depends on the cost. It depends on the side effects. But anyway, you end up determining that there's a minimum reduction that would make this medication worth it. Let's say 1%. And if you have this, a reduction of whatever this number is, so let's say this is 5%, goes from 2% reduction to 7% reduction, this is good. This is precise. This is statistically significant because it doesn't cross 1. However, there's a reduction of 0.5. Exactly. So the imprecision is not related to statistical significance, it is related to clinical significance. This is the minimally important difference. Yes, and this is why like about 1 year ago, the American Statistical Association had this famous, well-publicized paper where they said, p-value makes no sense. The reason for this is when you talk about p-value and you talk about statistical significance, you talk about whether the confidence interval crosses 0, which in real life, at least in clinical settings, makes not much difference. So I can tell you that this medication produces statistically significant reduction in stroke, I'll stick with migraine, and the confidence interval goes from reduction of 0.5% to a reduction of 1%. I don't care if it's statistically significant. It's not clinically significant, okay? And so that's what's important. Think about clinical significance. So when you talk about imprecision, the judgment that there is imprecision is whenever the confidence interval crosses the line of clinical significance, because we're not sure whether it's clinically significant or not. So I would like more data for this confidence interval either to move like this, and then I say it is definitely clinically significant. Hey, I don't care. هيدي it's not statistically significant, but it is clinically significant or it's narrow enough.
Why is it clinically significant? It's not crossing.
It's not as the clinically I'm happy with it لأنه it's narrow enough.
It's not crossing the.
Okay, you mean the precision.
يعني it goes from 0.5% reduction to 0.5 increase, but overall for me it clinically it has no effect.
Can we see this stuff usually in the meta-analysis?
Yeah, so this is a judgment. So when you look at a study, whether it's a it's an individual study or meta-analysis, you look at the confidence interval that is for that outcome, and you look at And then there are so for certain outcomes there have been values for the minimally important difference defined, especially for continuous variables like quality of life outcomes, functional outcomes. They have defined what is the minimally important difference, and you want this effect not to cross the line of minimally important difference.
5% or 1%.
بالMID, which is continuous outcome, it depends on the scale. طيب. Okay, I think we'll stop here.
Publication bias.
It's already 6:30. غير مرة. We talk about publication bias. I'll just go back and we'll talk about publication another time, all these factors. So maybe we could have a separate, maybe we could have a separate presentation about this. I'll just go back to the main.
Can we have this?
Yes.
PowerPoint?
So there was this discussion around. I'm sorry.
Just to summarize, so what you do, you start with assessing the study design, and then you go through all these factors: risk of bias, inconsistency, indirectness, imprecision, and publication bias we haven't covered. And then if you have problems with these, even if you start with randomized trial, you'll end up with a confidence that is not high. Could be moderate, low, or very low.
So here I'm talking about efficacy. So there was like consistent evidence based on randomized trial and even a meta-analysis that, for example, corrected cancer screening reduces mortality by 15% for those who are regularly being screened. But then this doesn't apply to at the population level, and this is what got me confused between clinical and public. So at the public level, you need to have a certain participation level in order to.
That's different. That's not what. Yeah.
That's not the same.
That's not the issue.
Okay, so this one is more about.
This is distinguishing between statistical and clinical significance. You're talking about
What matters at the public health level?
clinical outcome versus public health outcome.
Prevalence.
Efficacy again, more the efficacy part of it.
It's kind of more of the public health impact. So, when you screen, if you do it on a screening level and you do the screening, you detect the cancer, you treat it, so clinically it might work. But if you do it at the population level where you screen everyone, you detect cancer, but there's no chemotherapy available, there's no radiotherapy, there's no management available. In this case, there's no impact.
So chances are, for example, if somebody is screened, chances are it's not like, at an individual level that the mortality is going to be reduced by 15%, let's say, but then at the population level,
okay.
if
Okay, I got your point. So this is a challenging issue, because when we say there's a 15% reduction, does it mean that only 15% benefit will be ما حدا benefit? It's probably that everyone benefits a little bit, but when you do it in a dichotomous way, it ends up, the way it translates, there's a certain percentage that has benefited enough to be shown as a difference.
Yeah, similar to the trial, in other words.
So this is because you're analyzing the data in a dichotomous as opposed to the. If you do it in a continuous way, so for example, median survival, you say that the median survival is increased by 6 months. The way you interpret it, that each one of the participants has gained 6 months. Versus when you say 15% reduction, it's like you're saying 15% have benefited, 85% have not benefited. So the truth is in between. In most cases, I would say, هلا في cases where people do not respond, they don't even benefit in terms of the duration. But in most cases, probably what happens, everyone benefits to a certain degree. But when you dichotomize it, it ends up being like a percentage. That's what you want. Okay. She did not like it.
بدي اعمل مثل ما انت عملتي الساعة 12 الظهر.
Okay. Any other questions? To be continued?
Thank you so much.
Thank you.
Thank you for coming.
Thanks a lot for this.